Okay. Well, yes. So welcome. We'll start off with dental materials lecture first. I want to first go over before we get into just the lecture part of the course, I just want to go over some changes due to the weather. So let me pull up, let me share my screen here. Okay. So let's take a quick look here at the dental materials D2L page. So hopefully you guys get the announcements that I post on D2L. But I posted this announcement yesterday once we heard about the closure. So I don't anticipate that the college is going to be closed next week. I think that things are going to hopefully thaw out by Monday and things will be back to normal schedule Monday. So that being said, for this class, these are the changes. So quiz number 1, which we would have been taking now in class, is on D2L. I haven't checked and seen. I'm sure some of you guys probably got right in there and took it, which is great. But it's on D2L. It'll be available for a full week. So it's due next Friday at 9 a.m. So the start of this lecture class next week. It's an open book quiz. I can't monitor making them closed book when they're on D2L. It's not fair. So it's an open book quiz. So that's great. You guys will all do good. Just make sure you follow the instructions. But it's 5 questions, 10 minutes, just like it would be in class. It's the same questions that I would have given you in class. So that's the quiz. I extended the deadline for the worksheet from last week. So it can still be completed on paper or digitally. And it's going to be due either on D2L or at the start of class next Friday, the 26th at 9 a.m. And then obviously you're on this lecture right now, so you know what we're doing. So that's for the worksheet. The worksheet, I just extended the deadline on here, so it's now due on the 26th. So if you haven't turned that in yet, most of you guys have. If you haven't done it yet, you've still got until next Friday. You can also, if you decided you wanted to do it on paper and you want to turn it in person, just bring it to class next Friday and I will accept it that way. So that is the new due dates for stuff. This is the week 2 module here. So this is the lecture I'm going to go over today. And then there's the quiz there. I'm also going to put this week's worksheet in here. And I'll do that as soon as we're done with this lecture so that you have that worksheet. That worksheet won't have an extension on it because you're getting it today. So it'll be due next Friday. It'll be the normal due date for that. But I will give you the option to submit it digitally or in person. So either way, because I know some of you guys probably don't have a printer and you might want to use this weekend to get it done. So if that's the case, then you can do it digitally and submit it digitally. But if you want to print it and turn it in person, you have the option. So I'll post that after we get done with lecture today. Are there any questions about that? Do I need to clarify any of that for anyone? Okay, I'm really trying to make it as easy to understand as possible and also really give you guys ample time and ability to do it, because I know that when we have these types of closures, it just kind of messes everybody up a little bit. So hopefully that is okay. I'll talk about integrated basic science in a little bit, but it's a similar situation. I also just want to make sure you guys know we as faculty, we have looked at all the things that have been missed this week. Obviously, in-person things have to be made up. We need those hours to be made up for all those classes and for OHSU, Willamette Dental. We're still in the process of confirming all of that. But just make sure that you have your finals week open, because that's our big buffer period. We may need to use some days during the finals week to do makeup stuff. So just make sure that you're not scheduling anything yet during finals week. We are hoping to have the 2 things. We're hoping to have the finals week schedule finalized this coming week. And we're also hoping to have the edited schedule for where your lab makeups are going to be. We're also hoping to have that finalized by this week. I'm meeting with Peggy and Jessica this afternoon to talk about that. We just don't want to give you guys any information about stuff when we don't have like 100% certainty yet, like that all the faculty are going to be available. I still haven't heard back from OHSU to confirm the date I want to do the makeup. So we're just waiting on all that stuff, and then we'll get you guys that information. So we're trying to get it as fast as possible. Just want to make sure you guys know that. So any questions about that? Cool. Okay. I'm going to stop sharing for a second, and I'm going to switch to the PowerPoint for today. There we go. All right, so I'm going to go ahead and dive into our content for the week. So this week we are talking a little bit about intermediate restorative material, and then we're just doing a review, provisional coverage review. This is a really good week for both of my lecture classes because the information, most of the information we're going over is review stuff, which is great. So intermediate restorative materials. You guys kind of know a little bit about this already. So when we talk about an intermediate restorative material, another term for this is a temporary restoration. So something that is not going to be in the patient's mouth long term. It's meant to be replaced by something permanent. So intermediate means it's intermediate. It's in the middle of, something to come. So you can place an intermediate restoration on any tooth, any surface. We might choose a material, like one material over another, depending on how long we expect this to be in the tooth, where it is in the patient's mouth. Lots of different things might come into play. Why would we do an intermediate or a temporary restoration as opposed to just putting in a permanent restoration? Waiting to determine the health of a tooth. An easy example of this would be patient comes in, they have a really, really big cavity, right? Like it's a really big cavity. The patient is experiencing some symptoms, they're having some pain, and we don't know, like when we look at the tooth, we think, well, maybe we could put a filling in this tooth, like a composite or an amalgam, but it's such a deep filling that this tooth might need a root canal, but we're really not sure, like it's kind of borderline. So what we can do is we could remove the decay, put a temporary restoration in the tooth, and then give it some time, maybe a week, to see how the tooth responds. Once we've gotten the decay removed, does the tooth kind of calm down and the patient's symptoms subside? If that's the case, then we could take the temporary restoration out and put a filling in. But if the patient's symptoms don't subside, then we might have to move straight into doing a root canal. So it's a way to kind of wait and see how the tooth responds once we remove decay. So wait to determine the health of a tooth. Waiting to receive a permanent restoration. So obviously we make temporary crowns when a patient is waiting for a permanent crown. We would put a temporary restoration, like a temporary filling in if like a patient was waiting on an inlay or an onlay, because those are also indirect restorations that are made at the lab and follow basically the same process as a crown, but they're just smaller. Financial reasons. If a patient doesn't have the finances at the moment for a permanent restoration, or, patient's insurance hasn't turned over, maybe it's like they come in December, they've already used up all their benefits for the year. And we're like, well, in January, the patient's benefits are going to renew and, they're able to pay for this. So let's put a temporary restoration in now and schedule them back in January for the permanent restoration. That could be an option. And then primary teeth. Sometimes with placing a temporary restoration, they are, I'm going to say they're less technique sensitive because they're meant to be temporary. And so sometimes when we're working with kids and we're working with primary teeth, we want to do something that isn't going to be as technique sensitive because it's really hard to control kids' movements. It's hard to control their saliva. So it's easier to sometimes place a temporary restoration in their tooth. And in Oregon, placing an intermediate restoration is an expanded function. So if you get your EFTA certificate, which you all will, then this is something that you are legally allowed to do. You can place a temporary restoration in a patient's tooth. You're not removing decay or anything like that. The dentist would, remove decay or prep the tooth however it needs to be prepped, and then you would be the one placing the restoration. This is something that we will do in lab. I believe it's scheduled for lab 2. Yeah, so we'll be doing those in lab this coming week or next week. All right, so materials that we use. In lab, we're going to be using IRM. IRM, the chemical name is zinc oxide eugenol, ZOE. You guys all know this. You've mixed this. This was on our final. You are familiar with this. ZOE or IRM is the most common intermediate restorative material because we know it, even the name itself stands for intermediate restorative material, IRM. It's a composition of zinc oxide, which is the powder, and then eugenol, which is oil of clove, and that's the liquid portion. And we mix those two together. Remember, I know you know this, but I'm just saying it anyway. Remember that with IRM, we can change the ratio of powder to liquid depending on the consistency that we're looking for based on what we're going to be using this for. So yes, this is the most common intermediate restorative material, but we can also use this for other things, bases, temporary cement. IRM has a lot of different uses, which makes it very versatile. Important to know about IRM, so eugenol, the oil of clove, it has a sedative effect on the pulp. So like that example of when we would place an intermediate restorative material would be, if we're waiting to determine the health of a tooth. If a tooth is irritated, right, it has a really big cavity, the patient is experiencing some sensitivity or some pain, the eugenol actually has this like sedative effect. It kind of calms the pulp down. So it can help alleviate some of those symptoms because it has that property, which is a reason why this material has been around for so long and why this is so commonly used still in dentistry, is because that's a really good property to have. And then another material that is becoming more common for intermediate restorative or intermediate restorations is glass ionomers. So we've talked about those before. We know that glass ionomers can be used for many different purposes, very versatile. There's different compositions of glass ionomers based on what application we're going to be using it for. Fuji is a very common, if not the most common brand name. You guys have all mixed the Fuji capsules. And that's one that you're going to probably see often out in the real world. Biggest property that we look for, or biggest benefit to glass ionomers, is that fluoride release. So they contain fluoride, they're going to release fluoride. So again, if you're placing a temporary restoration in a tooth, well, whether you're using glass ionomers to place a temporary or a permanent restoration, because remember, they can be used as both. If you're placing it as a temporary restoration, and let's say you just removed a bunch of decay, that fluoride release is really going to help remineralize that area of the tooth. So again, big benefit. Both of these materials, IRM as well as glass ionomer, lots of benefits when used as intermediate restorations. All right, any questions about intermediate restorations? Okay, there's only a few slides, but hopefully some good information. We've reviewed those materials before, just really talking about how we're using them as provisional or intermediate restorations. So now let's move on to, instead of intermediate fillings or restorations, intermediate provisional temporary crowns, temporary coverage. So we went over this last term. We did a whole lecture on it, and you guys have made provisional crowns now. Now that you've been making some provisional crowns, we're going to do a little review of this. The reason we're reviewing it, and the reason I try to have you make a lot of these in lab, is because this is an expanded functions for dental assistants, and it's something that is very frequently done as a dental assistant in a dental office. Most dental offices will have their dental assistants making temporary crowns. Very, very common. So I want you guys to be really good at it. When it comes to, if we back up to when we just talked about intermediate restorations, honestly, I don't find that dental assistants do this very often in the real world. Yes, you're legally allowed to do it as an EFTA, and you probably might do it a time or two, but most offices, this will be something that the dentist does. And that's just kind of how most offices function. So again, it's kind of a personal preference of the dentist and how they run things. But just in general, placing temporary fillings or intermediate restorations is not common, but making provisional crowns is very common. So anyway, I'm not going to go over this provisional coverage review in like super detail because we have been over it. But again, since you've been making some, having this review is going to be really good. So provisional crown, these are meant to be temporary. The purpose of a provisional crown is, it has a lot of purposes, but mainly it's to protect the tooth. In general, it's protection of the tooth. When we prep a tooth for a crown, we remove all of the enamel as well as a portion of dentin. So we've exposed just dentin tubules over the entirety of this tooth. It's going to be, for most patients, the majority of patients, super sensitive. We need to make sure that we're reducing that sensitivity. So placing coverage on it is going to reduce sensitivity. It's going to maintain function and aesthetics of the original tooth. So the patient's going to be able to chew and eat. They'll be able to talk. If it's a front tooth, obviously we want them to have something that looks like a tooth there, you know, because they have to like go about their lives. We don't want a tiny little peg of a tooth. So it's going to help to maintain aesthetics and function. It's going to protect the margin of the preparation. Remember that the margin of the prep is this little kind of ledge down at the bottom near the gum line, where the tooth has been prepped. That's the margin. And we want to protect that because when the permanent tooth or the permanent crown comes in, we want to make sure that it lines up perfectly, like as close as perfectly possible with that margin. So when we say protecting it, we're basically saying we don't want to chip the tooth, we don't want it to break. So the provisional crown is going to help us to protect it. Prevent the adjacent teeth from shifting. And I'm kind of pointing to this picture here to just kind of illustrate some things, but you can see that this prepped tooth here that's been shaved down, when we shave down the enamel around the tooth, we are opening up the contacts, right? So we're creating space between this prepped tooth and the adjacent teeth. And what's going to happen is even over a period of a week to 2 weeks, these teeth that are on opposite sides here, they're going to start to move into that space. They're going to slowly start to shift and try to close the contact space. And we don't want that. So by making a good fitting provisional crown, we are going to hold those teeth in place. And then we're also going to prevent the tooth from supra-erupting towards the opposite arch. So same thing, teeth are always going to erupt or move until they meet an opposing force. So this prepped tooth here, since we've shaved off all the enamel and some dentin on the occlusal, the tooth now does not touch the tooth above it, right? There's some space there. So this tooth is going to want to erupt. It's going to want to keep pushing out until it hits those maxillary teeth. And we don't want that. We don't want it to supra erupt. So we want to keep it in place. So temporary crown is going to help with that. And then just, yeah, protecting the tooth from damage or breakage. Overall, it's protecting the tooth. Okay, so crown prep, the first appointment, we're going to take a shade. The dentist is going to prep the tooth with a burr or a series of burrs. We're going to take a final impression and bite registration that we send to the dental laboratory. And then after that is done, then we're going to make the patient a provisional or temporary crown, and we're going to temporarily cement it in place. And that appointment is done. When they come back for the crown seat appointment, we are going to remove the temporary crown and we're going to clean off any temporary cement that might be there. We're going to try on the final or permanent crown and make any adjustments to the occlusion or the contacts that are needed. We're going to make sure that it fits well. And then once we've got it fitting well and we know that it's good, then we are going to cement the final crown with a permanent or a final cement into place. Now, when it comes to this crown seat appointment, you as a dental assistant are usually going to be the one that takes off the temporary crown and cleans up the tooth. You are the one who's going to preliminary fit the final crown, and you can make adjustments to it. And then once it's all adjusted and looks good, the dentist will come in and check it. And then they are the ones to actually cement it, and you assist them with the final cementation. So types of provisional crowns. We know custom provisionals. This is what we've been doing in lab, is making custom provisionals. We know that we take a preliminary impression in order to do this. So we take an impression of the patient's tooth before it ever gets prepped. So before a burr ever touches that tooth, we take an impression that we use as the mold. We make this crown chair side. It's customized for the patient. It's made out of an acrylic or a composite resin type material. There are different types. We're going to cement it with temporary cements, and there are shades that we can buy of this. I think in lab I have A35. I like to do a darker shade when we're in lab, but usually you'll have probably like an A2 in an office because that's just a really common shade of patient teeth. But you might have multiple colors that you can choose from, especially if you're doing a lot of anteriors. So preliminary impression, lots of things we can use to make these. We have been using the little matrix buttons, which is this bottom picture here. Those work really well in lab, but I have not really seen those used on human patients because I think it requires that hot water bath or having some sort of way to heat the material. And most offices don't have that just around because it's not something that's used commonly. Most offices will use a PVS, polyvinyl siloxane material. Usually something that's similar to what they're using for their final impressions, or that putty material that we played with at the end of last term. So the material we use this material that's shown up here. This looks like ours. This is called Integrity. Chemically, this is the same material that we use. We're just using like a off-brand, I guess, or it's a cheaper brand of material, but it's the exact same chemical material. It's an acrylic, it's a monomer and a polymer. It comes in the cartridge, and there's two, parts to the cartridge, and then it has a mixing tip that we attach to it. There are also composite custom provisional materials. Those are bisacrylics, and you can get different varieties of them: self-cured, auto-cured, dual-cured, just like the types of composites that you can get that are used for provisional crowns are similar to the types of composites that you would use for composite restorations. So not very common. Honestly, the most common custom provisional material is what we are using in lab. It comes in the cartridge, it's an acrylic, monomer and polymer, mixed tip, and that's what most people use. Trimming, you guys know about trimming these. You guys have been using the discs with our lab burrs. In an office, most of the time, you're just going to use whatever is there that the dentist has used to make or to prep the tooth for the crown. Usually there's some type of like a long diamond burr that they use to prep the tooth for the crown. And that you would just grab that and use that to adjust your provisional, because that's what you have on hand. They work really well. It's efficient. It's already there. It's already dirty. That's just what most people do. But there's a variety of different types of burrs you could use. Oh, and with that, you can use either a slow speed or a high speed to do this, because you're doing this outside of the patient's mouth. And so you cannot use a handpiece inside the patient's mouth, or a high speed handpiece inside the patient's mouth, but you could use it outside the patient's mouth. So like this picture is a high speed handpiece that they're using to adjust this, and you can definitely do that. And that's really efficient and easy to do. So preformed polymer crowns. I don't see these very often, but they exist. They are like these little shells. They're a plastic shell. We fill it with some sort of a composite material that we then place on the prepped tooth. We let it set, we would adjust it, and then temporarily cement it in place. Again, I've never seen these used actually, but they do exist. And these are what people really used before the provisional materials were, or the custom provisional materials were really fine-tuned. When you're selecting a preformed crown, I'm going to go over this a lot more in lab this term, but when you're looking at preformed crowns, they come in different sizes from dental companies, and you're really trying to select a size that best fits the patient. And we're always looking for the same things that we would look for when we're making like a custom provisional. We want to make sure occlusion is good. We want to make sure we have good contacts. We want to make sure that the crown fits well at the margin. So we're really looking at getting the best overall fit when we're selecting a preformed crown. And again, I'll teach you how to do this in lab when we talk about stainless steel crowns. Polycarbonate crowns, these are mostly used for anterior teeth. The book says that, but honestly, I think most places are just doing custom provisionals for anterior teeth. So I wouldn't say that this is the choice for anterior teeth by any means, but it's definitely an option. These are, you can see that they come in different sizes. They also come in shades, and you select one that best fits the patient's tooth, and then they are temporarily cemented in place. And there's no real customizing about these. And there's a picture of kind of how you would select one. So again, obviously, like this is tooth number 8 that they're selecting for, tooth number 9 right next to it. This polycarbonate crown looks nothing like this tooth, in my opinion. So it's not going to be like the best looking aesthetic choice for our patient. A custom provisional is always going to be the best. And then stainless steel and aluminum crowns. We will be doing these in lab this term. I think it's lab 3. These are made from a medium hard material. They've got good durability. Commonly used on primary posterior teeth after endodontic treatment or removal of severe decay. So these are really meant to help give a primary tooth function until it falls out or is exfoliated. Obviously, we're using these when we don't really care about how it looks. That's not to say we don't care about how kids' teeth look. It's just not as important for kids versus adults. And we also know, again, that these are going to be primary teeth and they're going to be exfoliated. They're going to fall out. So we're not going to be like living with this stainless steel tooth forever. Stainless steel crowns are thicker than aluminum crowns, so they're used for more long-term coverage. Aluminum crowns, if you think of like an aluminum can, pretty soft when it comes to metals. So aluminum crowns would be used for more of a very short-term situation. And we'll go into stainless steel crowns in more detail when we get into lab and we actually play with them. Trimming aluminum and stainless steel crowns, there are specific tools we use for those. We use what are called crown scissors, and then we've got crown contouring pliers. And again, we'll go into detail about this in lab because we'll actually do it. Criteria for provisional crowns. This is the same no matter what type of a provisional crown you're doing, whether it's a custom, a stainless steel crown, a polycarbonate crown. We're always looking for the same things because we want this to be a really good, solid fit for our patient. So making sure that our technique is good. We want to be really precise with this. The fit has to be very snug. We don't want the tooth to rock or have any movement. If you imagine it can move, how's the patient going to eat with a crown that's rocking or moving? We don't want that. The margin has to be less than or equal to 0.5 millimeter, which is nothing. That's very, very small. So what that means is that, if this is our temporary crown on this tooth here, and this down here, this white section that's tooth, that black line is the margin. The margin is where the crown meets the tooth structure. We want a gap of no more than 0.5 millimeter. So basically what we're saying is we don't want any gap at all. All right. Interproximal contacts. We need to have contact between the adjacent teeth. We need to, when we floss, we want there to be a little snap because we want to keep that contact. If we don't have contact, 2 things are going to happen. One, those adjacent teeth are going to want to move into that space. So they're going to shift, which is not good. And then the patient, if there's an open contact, they're also going to pack food in there. So that's already going to be a sensitive area because we've been working on this tooth. And if we start packing food in there, that's going to start to irritate the gums. That can lead to issues. Proper occlusion. When we talk about occlusion with temporary crowns, we basically want the tooth to be out of occlusion. So we really don't want it to be occluding or hitting with the opposing tooth. So if it's a mandibular tooth that we've got a temporary crown on, we don't want it to hit the maxillary tooth. And if it does, we want it to be very, very light. So we want to make sure to kind of take down the occlusion, but at the same time, we don't want to make a flat tooth or anything like that because that can encourage super eruption. So we don't want that, but we want it to be just extremely light occlusion, if anything. So when we check it with our articulating paper, we want to see no blue marks or we want to see really, really faint blue marks. Appropriate aesthetics, we obviously want it to look nice for the patient, and we want to make sure that we can remove it without harming the tooth, which I'm not sure. I mean, I guess if you permanently cemented it, that wouldn't be good, but we want to make sure that it's something that can be removed without harming the actual tooth. Here's another picture of some of the criteria. So again, contacts, occlusion, making sure that our contours are good so that we can deflect food, and making sure that that margin is nice and solid. How long are we using these? So they're temporary. Both acrylic and aluminum, they are not intended to be worn for more than 30 days. Usually, if we're doing a temporary crown, it's usually for about 2 weeks. That's usually like the kind of tops average time that we'd have it in there. But 30 days is about how long, we'd really want to max time we'd really want to be using it. Stainless steel crowns, those are considered long-term temporaries. So those can be used for a longer period of time. How long? I mean, gosh, maybe up to a year. I mean, it just depends. There's a lot of factors that would come into play. But with stainless steel crowns, those are typically permanently cemented into place. So they are meant for long-term use. But again, they're not customized to the patient's tooth. So they're never going to be as good as like a real permanent crown would be. So we are not going to intend for these to be permanent situations. Cement removal, anytime we cement a crown, whether it's temporarily cemented or permanently cemented, cement is going to squish out. We kind of want that because we want to make sure we have enough cement. So some's always going to squish out and then we have to clean it off. Usually what we do is we'll give it a minute to set, and then we'll use an explorer to remove cement from the margin. We never want to leave that cement there for the patient. I mean, if you really think about it, some of it's probably going to flake off, but it's going to irritate the gums. So we want to make sure that we remove any excess cement before the patient leaves so that their gums are nice and healthy. Ways that we can remove a provisional crown. There are crown removing instruments. We can use hemostats. We can use a spoon to remove it. I've taught you guys for when you're removing your provisional crowns to use the spoon. We use a large spoon, not a small spoon, but that's really a good gentle way to do it. Using hemostats or like a crown remover instrument, like the picture here, they work well. You pinch the side of the tooth and you put pressure on it, and then you kind of break the seal by wiggling it. They work well. The issue is if a patient is coming in for a crown seat appointment, they are not numb. Their tooth is not 95% of the time, that patient is not numb to get their crown seat. So we are going to be really, really gentle with them when we do this. When you take that crown remover or a hemostat and you squeeze the temporary crown to remove it, for most patients that can be very sensitive and that can cause them pain. And so if we're going to use that instrument, we want to be super gentle about it. But what we usually want to do is just start with a spoon and see if we can break the seal at the margin with a spoon before we actually put pressure on the tooth, just because that's what's more comfortable for the patient. So that's why we would choose to use a spoon over a crown remover or a hemostat, is just because we don't want to be putting all that pressure on the patient's tooth. It's kind of like start with the spoon, see if you can get the crown off. If you can't, then you'd move up to the crown remover or a hemostat, but being very, very gentle with it. Provisional bridges, those are also a thing. So if we're making a bridge for a patient, we obviously want to send them home with a temporary solution. So provisional bridges are that option. We may or may not make these in lab this term. I usually like to teach it, but I would say most people typically learn this on the job from the dentist they're with, because there are different ways that you can make them. But they do exist. It's basically 2 provisional crowns on either end. And then those are the abutments, and then the Pontic in the middle, where we're replacing the missing tooth. They are all attached, but it's all made out of that same custom acrylic material. All right, reminders for next week. So next week, we should be on campus. I don't anticipate any craziness, but as long as everything goes as normal, we will have quiz number 2 at 9 a.m. We'll be covering this PowerPoint. And then your worksheet will also be due at 9 a.m. So again, I will, let me do this right now. This is going to be either in person or on D2L. So I will post that on D2L. I'll have an assignment folder for it. So you can feel free to print it and hand it in person, or you can do it and submit it digitally. Either is going to be fine, but due date will be next week at 9 a.m. All right. Any questions about that lecture or that class? Cool. Okay. Well, what I'm going to do is I'm going to go ahead and let's take a quick break. Let's take a 10-minute break. I'll get my PowerPoint up for integrated basic science, and then we'll dive into that. So it is 9:37 right now. Let's come back at about 9:47 and we will go with integrated basic science. I'll see you guys in a few minutes. Thank you. All right, everyone. Welcome back. Hopefully, welcome back. Hopefully some of you guys are still there. Okay. So integrated basic science. First, I want to start by saying that during that short break, Jessica had asked if I could be part of a meeting at 11. So I told her that I would try to get you guys out of this Zoom by 11. So I think we can do that. So a couple things. Sorry, I'm a little all over the place. First, I want to tell you guys that for this class, we have some updates, just like we did for dental materials. So let me share my screen and go over those real quick. Okay, so here is the D2L page. So the quiz that we would be taking in this class right now is on D2L. Again, open book quiz, follow the instructions. Because this class is integrated basic science, it's a longer quiz, so it's 10 questions. You've got 20 minutes to do it. Open book, and you have all the way until next Friday to get it done. Same thing with the worksheet. I've extended the deadline to next Friday, so you can do it on paper or digitally. You can turn it on D2L or at the start of class next Friday. Totally up to you. We had last Friday, I had assigned coloring pages. Those are going to be due in person next Friday. So there's no submitting those online. Just bring those with you when you come to class next Friday, and I will collect those then. And here we are for lecture. So those are the updates for that. This week, we don't have any coloring assignments this week. We just have a worksheet. So I will post that on D2L after the lecture so that it's on D2L, and you'll have the same option. So you can submit it digitally, or you can bring it to class with you next Friday. Whichever works for you is totally fine. So that's our update there. Any questions about that? Okay, hopefully that's fairly straightforward. I don't think my explanation is super straightforward this morning. Again, sorry if I'm a little all over the place. Let's go ahead and take a look at our lecture here. So one thing I want to say about the lectures for this class is, I think I kind of mentioned this last week, but I went through with these lectures, and I've done these lectures a little differently for this course, in that I really tried to put a lot of information in the lecture. Like, you'll notice that the slides are very wordy, right? If you know anything about making PowerPoints or slides, they always say, like, just put very little text. They're like just short bullet points. And then when you lecture or you talk about it, you're supposed to add information. But what I find with students is that a lot of times they prefer more information, because if I put more information from the book in the slides, you don't have to refer to the book as much. I'm not saying that doesn't mean you have to do the readings or anything like that, but I find that students prefer it. So I'd really like to know if you guys like that or not. And you don't have to tell me that today, obviously, or anything like that. But just know that that's something I'm kind of experimenting with this class, to see if you guys find this amount of information on the PowerPoints to be really overwhelming, or if it's good, like as far as, when you go to study for quizzes and tests, like, do you prefer that all this information is in the PowerPoint, or would you prefer that the PowerPoints are simpler and more streamlined? I'm just trying something to see what works. So anyway, I just want to let you guys know that I know that these PowerPoints this term are very wordy. And I'm just trying to see if that's helpful or not. So you guys can feel free to, let me know if that works for you or not. So today's lecture, we are doing a review of embryology and histology. Since Jessica wants me to be part of this meeting, and this is kind of a lengthy PowerPoint, and this is a review of material we covered last term, what I'm going to do is I am going to go through it, but I'm going to really highlight some key points. And specifically for those of you that are actually paying attention to this Zoom session, I'm going to try to highlight the quiz questions for next week so that you guys kind of know what's up. So hint, hint. Okay, let me check here. Okay, just check in the chat there, since some people were telling me some stuff. Okay, let's go ahead and start the slideshow. Oh, that's not how I want to do it. don't want presenter view. Oh, I see what I'm doing, you guys. Hang on a second. I had my second monitor plugged in and that's why it's playing like that. Okay, so review of embryology and histology, way back to last term. So embryology. Embryology is the study of prenatal development through the stages before birth. So this is what happens before birth, right? When we're talking about embryology in terms of dentistry, we're really looking at like how are these structures, how are the dental structures developing, right? So our focus for this course is we want to have an understanding of what's going on, you know, fully with the human body and with development. But we do want to really focus on development of tooth structures and when and how those things happen. So prenatal development, 3 periods that happen. So we have pre-implantation, we have embryonic, and then we have the fetal period. So pre-implantation, this occurs the first week after fertilization. So pre-implantation, this is before this implants into the uterus, right? So the egg has been fertilized, things are happening, but implantation in the uterus has not yet happened. Embryonic period is what occurs after it has implanted, and this is the beginning of the 2nd week to the end of the 8th week. So this is when the developing human is considered an embryo. And then we have the fetal period. So this is beginning of the 9th week, and then this ends at birth. So it's a fetus until it's born, then it's a baby. So in the pre-implantation period, this is when fertilization happens. When the egg and the sperm unite, this is called a zygote. Inside the zygote, that is where we have our chromosomes that are uniting. This process is called meiosis. And then those chromosomes are what's going to determine different characteristics of the forming human. And what we know and what we talk about is that some things can happen during this period where, you know, chromosomes do kind of funny things, and those can lead to some kind of disorders in, well, within the whole of the human body. But for us, we look at, you know, things that happen within the mouth. So discrepancies with tooth to jaw size, different types of developmental things that can happen that affect our teeth and our head and neck region. Embryonic period. So implantation happens. We now have an embryo. This period is super critical because this is when all the major structures of the body begin to form. Cells are starting to proliferate, which means they're increasing in number. So we've got a lot of splitting, developing. These cells are just multiplying and multiplying. So that's proliferation. That's happening at a really fast rate. Differentiation. So differentiation, we talked about this a little bit last week when we talked about anatomy and physiology, but differentiation is when those cells are going to start to decide what they're going to be. So at first they're kind of just cells, right? They're dividing and dividing, and then the cells are like, oh, I need to be connective tissue, or I need to be muscle tissue. And then they decide, oh, now we're going to we're muscle tissue, we're going to form this muscle, or we're this type of tissue, we're going to start to form this organ. And then those things come together and start working in systems. So all of this is starting to happen in this embryonic period. So it's a really, really critical period for development. So then after that, we enter the fetal period. So this is week 9 until birth. So again, this is when the developing human is considered a fetus. So everything is continuing to grow and develop. This is when the developing human starts to have more distinguishable body parts. They don't look like a little tadpole anymore. We start to really see their more humanistic features. Because all of the organs were formed during that embryonic period, the fetus is a lot less vulnerable to malformations caused by things. Remember that embryonic period, that's where it's kind of the most critical phase for developmental like abnormalities. Things can still happen during the fetal period, but the fetus is just a little bit more protected because things have already formed and now they're just kind of maturing and growing. So now the oral cavity, embryonic development of the face and the oral cavity. So we have our primary embryonic layers. So during the third week, these layers form. We have the ectoderm, the mesoderm, and the endoderm. Those three layers of the embryo develop into different parts of the body, which are listed here on this slide. And this should be familiar from last term. You don't need, none of this is on the quiz. So you don't need to remember what the ectoderm forms or anything like that. But just remember that this is what's happening. The primitive mouth, when the mouth is first starting to form, it's called the stomodium. That's the primitive mouth. I would remember this for the quiz. So this is the stomodium right here. This is what is going to form into the mouth. And what else do I want to say about this? Down here, these are the branchial arches. We'll talk about those, I think, in the next slide. But stomodium. Stomodium is the primitive mouth. And yeah. Okay, so there's our branchial arches. Again, the branchial arches, those form into different things in the body, right? So like if we're looking at arch 1, which is considered the mandibular arch, that's going to form these following structures, right? So each arch we know is going to develop into these things. You don't need to know these for the quiz, but I would just remember that, you know, this is part of the development, but you don't need to, I'm not going to ask you a question like, which arch do the stapes of the ear come from? I'm not going to ask you that on this quiz. Hard and soft palates. So this one's a big one, especially when we're talking, you know, when we focus in on dentistry. So during the 5th week, that's when our palate starts to form. So we have the primary and the secondary palates that fuse together. There are 3 parts of this process. So we have formation of the primary palate, which is in the anterior here. It's this dark purple area. Then we have formation of the secondary palate, which is this lighter medium purple area here. And then we have fusion. So those are the steps that occur in that process. And if there is disruption during this process, that can result in cleft lip or cleft palate or a combination of those two. I'm not going to ask you a question about this, but that's kind of a important thing to know when it comes to dentistry and embryology as it relates to dentistry in the oral cavity. Facial development, this is primarily occurring between the 5th and 8 weeks. You can see kind of the process of how things form and morph and change, and lots of things happening during that time. Tooth development. So at 5 to 6 weeks, this is when we first start to see signs of tooth development. And I mean, really think about that. Like the sperm and the egg merge, and then at week 5 weeks, we've got teeth developing. Like that kind of blows my mind when you really think about it in a short time frame. But at 5 to 6 weeks, we start to see teeth developing in the anterior mandibular region. That might be important to remember. That's where we start to see it. And then shortly after that, we start to see it in the anterior maxillary. And then things progress posteriorly from there. By the 17th week, all the primary teeth are developed and the permanent teeth are starting to develop kind of, you know, underneath of those. Developmental disturbances, these can happen at any stage of development. So we talked about how during the embryonic stage, that's the kind of the most critical stage for things to go wrong. But these can happen during any stage. So we want to make sure that we're aware of that. And there's lots of different things that can, when we say something can go wrong, there's lots of different things. So genetic factors can cause disturbances. Most common genetic factor is discrepancy between tooth and jaw size. So teeth that are too big or teeth that are too small, jaw is too big or too small, discrepancies in that, and those can cause various forms of malocclusion, which may or may not need to be corrected because those can cause some issues. And then environmental factors. Environmental factors, we call those teratogens. Those include infections, drugs, exposure to radiation. And when we say drugs, those can be prescription or non-prescription drugs. There's just lots of things that, when we put those things in our body, those can affect that development in different ways. So after birth, we have development occurring, right? Obviously, like a baby is very small, and then we grow into these big humans. So development happens after we're born. So things are growing, things are developing. Most growth occurs in really predictable spurts. Like we kind of know when these growth patterns are going to happen because humans develop in a really kind of specific way. When facial development is happening, we have deposition and resorption of bone, right? So bone is resorbing in some areas and being deposited in others. This picture here is trying to show you how the jaw grows, right? So this is your mandible. This is the bone, the mandible, and it's growing, right? It grows from a little baby mandible into an adult mandible. And so where it grows, that is where bone is being deposited, and where bone is moving, that is resorption. So bone is resorbed in one area, deposited in another, and that is how bones grow. So there are cells that are responsible for that. We've talked about this. So osteoblasts, those are cells responsible for new bone formation, and osteoclasts, those are the cells that are responsible for bone resorption. Modeling, this is also known as displacement. This describes bone changes that occur along the joints as they increase in size and shape. And then remodeling is growth and change in the shape of an existing bone. So a couple terms I don't think we talked about too much last term, but I'm not going to ask you a question about those. I might ask you a question about the difference between osteoblasts and osteoclasts. Those are really good cell definitions to know. Tooth movement. So again, remodeling. This occurs in response to forces that are placed on the tooth within the socket. So when we talk about forces being placed on the tooth and tooth movement, braces or orthodontics, this is a big one. You guys are going to dive into this in spring term when you have expanded functions. But yeah, so remodeling. So here you can see this tooth. It's got a little bracket and a band, or a bracket and a wire on it. So this is a tooth that is currently undergoing orthodontic treatment. So what's happening is that there is tension and compression. So there's pressure being put on this tooth in this direction, right? Let's say this is mesial. It looks like it would be mesial based on the shape of this tooth and the curvature of the root. But so we're putting pressure on this tooth, trying to push it more mesial. So we're trying to push this tooth towards the midline. So you can see the periodontal ligament here. We have this zone of tension and a zone of compression. Because we're pushing the tooth towards this area, it's compressing the periodontal ligament, and that's causing this bone to start to be resorbed. In this side here, on the distal side of this tooth where we have tension, we're pulling on the periodontal ligaments. So that is signaling this bone to make new bone. So there's bone deposition happening. So more bone is being laid down in there. So that's what's happening during tooth movement, is this remodeling of bone. Resorption and deposition, that's the remodeling process. And again, when you go into expanded functions, you'll dive into this a lot. All right, so the life cycle of a tooth. So the process of tooth formation, this is called odontogenesis, and we've got 3 primary periods. We've got growth, calcification, and eruption. And when we look at the growth period, there are 3, the growth period is divided into 3 stages. So we have the bud stage, the cap stage, and the bell stage. So kind of, I would know the difference between, like, okay, so the process of tooth formation, that's called odontogenesis. We divide that, odontogenesis is got 3 periods: growth, calcification, eruption, right? So growth is like the tooth is growing. Calcification is when it like solidifies, and then eruption is when it pushes out, right? Those are the 3 periods of odontogenesis. When we look closer at just this growth phase, so just the formation of the tooth, we've got these 3 stages. So these are like the sub-stages of growth, and that's the bud, cap, and bell stages. So bud stage. This one is also known as initiation, and it's the beginning of development for each tooth. This starts with the formation of the dental lamina. The lamina then produces 10 enlargements, which are the tooth buds for the primary teeth. And then the permanent teeth, they develop similarly, where the dental lamina continues to grow. And then succedaneous teeth, those develop from tooth buds in the deep portion of the dental lamina. I don't know that I really need you to like memorize any of this. Yeah, remember, I'm not going to ask you a question about this, but succedaneous teeth, that's just a really important term to know. And so remember, succedaneous teeth, a succedaneous tooth is a permanent tooth that replaces a primary tooth, because not all permanent teeth are succedaneous, right? Like our first and second molars and our third molars, all of our molars, those are non-succedaneous because they don't replace primary teeth. Our anterior teeth and our premolars, those are the succedaneous teeth because they push out a primary tooth or replace it. Cap stage. So the cap stage, this is known as proliferation. So cells are growing and increasing and starting to change. What do I want you to know here? I mean, I don't know that I'm going to ask you any questions about this, but yeah, lots of cell differentiation happening, lots of things starting to decide what they're going to be. So what's going to form the dentin, what's going to form the pulp, things are kind of starting to figure themselves out in the cap stage. Bell stage, more differentiation, cells are becoming more specialized. A process called histodifferentiation is happening. So we have epithelial cells, those are going to become amelioblasts, which form the enamel. We've got odontoblasts, which are going to form the dentin, cementoblasts that are going to form cementum. I'd probably know those three. I think those are kind of, I mean, maybe I shouldn't say easy, but I think, knowing that amelioblasts form enamel, odontoblasts form dentin, cementoblasts form cementum, knowing those is probably a good thing. And then I'm not going to ask you a question about this, but DEJ and CEJ, those are really important terms to know. Know what the dento-enamel junction is and the cemento-enamel junction. Those are the junctions between those two structures, right? So DEJ, dentino-enamel, the structure between the dentin and the enamel. Sorry, there's a typo right there. And then the CEJ, where the cementum meets the enamel. All right, then calcification. So calcification is where the tooth calcifies, right? So this is the process by which the structural outline formed during the growth stage is hardened by the deposit of calcium and other mineral salts. So we are calcifying our tooth, we're calcifying that enamel. So enamel is built layer by layer, going outward from the DEJ, starting at the top of the crown. So we just work our way out, calcifying on the way out. During that time, pits and fissures form, right? So calcification is forming or happening. The enamel is hardening and forming as different minerals are being laid down, and that's going to form those pits and fissures. And those happen where these different cusps coalesce or they merge together. A fissure is a fault along a developmental groove, and a pit is where two grooves come together. So a fissure, you can think of those as like the lines. The grooves are like the lines, and then a pit is where they come together. So a pit is where any grooves merge at like an intersection. Tooth eruption. So eruption of, oh, that's a typo. P shouldn't be there. It should say eruption of teeth. So eruption is the movement of the tooth into its functional position in the oral cavity. That's the definition of eruption. Eruption of the primary and permanent teeth takes place in chronological order. So can be some variation between individuals, but in general, teeth erupt at a specific time and they erupt in a specific order. We know how it occurs, but we don't understand why it occurs. So there's still a lot of mysteries in science. And during this time, we have what's called teething. This is an inflammatory response of the body, which can be not very comfortable to babies and kids. Shedding of primary teeth. So when a primary tooth falls out, it's called exfoliation, okay? And this is a normal process of losing teeth. So exfoliation is the term for how we lose a primary tooth. The osteoclasts, those cause resorption of the root that starts at the apex and works its way up to the crown. And then the crown, just the enamel, is what is lost. So when a primary tooth falls out or is exfoliated, what's actually falling out is just the enamel crown, because all the rest has been resorbed by the osteoclasts. All right, so that was like our little embryology review. Now we're going to go into histology. So histology, this is the study of the structure and function of tissues on a microscopic level. So we have the crown. So in the crown, we know we have the dentin, which is covered by enamel. And then each root in the dentin is covered by the cementum. We talked about the CEJ, that is that line at the neck of the cervix where the cementum and the enamel meet. The anatomical crown is the portion of the tooth that's covered with enamel. Clinical crown, that's what's visible in the mouth. Know those definitions, those will be important. And I always think of it, if I'm trying to remember the difference between the two, I always think clinical crown, you're in the clinic looking at a tooth and it's what you can see. So the clinical crown is what's visible in the mouth, like when you're in the clinic looking at the tooth. And then anatomical is like what is just actually covered with enamel. All right, the root. So the root is the portion of the tooth that is embedded in the alveolar process, and the root is covered with cementum. So no enamel on the root, just cementum. It can have 1, 2, or 3 roots. The tip of the root, the end of it, is called the apex. If we have a structure that is situated around it, we call that apical. And anything that surrounds the apex is called periapical. Most common thing we're going to say is periapical is like a periapical abscess, right? So if we look on an x-ray and we see a little abscess around the root, we're going to say that's a periapical abscess. Enamel makes up the anatomical crown of the tooth, and it's the hardest material in the body. Know that. Enamel is the hardest material in the body. Very, very strong. It's translucent and it can range in color from yellow to a grayish white. I really like this picture of these anteriors because this specific person's teeth, their enamel is quite translucent. Like you can really see the translucency of it in some of these areas and just like the range of color in this enamel. It's cool. Enamel, it's formed by the amelioblasts. It is primarily inorganic matrix or inorganic matter, and then a little bit of organic matrix. Hydroxyapatite is the most abundant mineral component, and that is what is lost when decay happens. Enamel is composed of millions of classified enamel prisms. These are also known as enamel rods that extend out from the surface of the dentino-enamel junction. They're grouped into rows. Prisms within each row follow a course that is perpendicular to the surface of the tooth. So they're growing out. Yeah, I'm not going to ask you any questions about this. I will not ask you any questions about this for sure. I know that these things are getting a little like into the weeds about enamel, but your book does cover it. But there's lots of different little substructures or things within the enamel, right? We have these different types of bands or stripes. And then we have these little tufts and spindles, all parts of the enamel that are contained within it. And they can tell us different things about how the tooth developed, things like that. The dentin. So in primary teeth, the dentin is a very light yellow, and in permanent teeth, it's light yellow and somewhat transparent, and it can darken with age. It typically does darken with age. Older patients typically have darker enamel. It's a mineralized tissue. It's harder than bone and cementum, but it's still not as hard as enamel, formed by the odontoblasts. Dentinal tubules. So important to remember that the dentin has dentinal tubules, and inside each of those is a dentinal fiber. I really liked this picture that I found. if we look at this, we can see that each of these blue spaces, these are the dentinal tubules. These are our little nerves in there, our little dentinal fibers. And then this picture here, it's kind of like a side view. You can see the little tubules, they've got this like the dentinal fluid in there. Here's our little fiber or our nerve. And then and different things can cause sensitivity, but this is showing like cold water could hit that, or toothbrush bristles having like some sort of mechanical trauma to that area or mechanical action can cause sensitivity, because that's going to travel down that dentinal fluid. It's going to hit that dentinal fiber, and that's what's going to cause pain. 3 types of dentin: primary, secondary, tertiary. So primary dentin formed before eruption, and this is most of the dentin. Secondary dentin, this happens after eruption, and it continues throughout the entire life of the tooth, but just very, very slowly. And it narrows the pulp chamber. So if you compare x-rays of someone when they're very young versus very old, their pulp chamber is going to be more narrow. That's because that secondary dentin is narrowing the pulp chamber as it develops. And then tertiary dentin, this is also called reparative dentin. This is just formed when there's irritation. So this may or may not be happening, but it's a localized spot of dentin that's deposited where there is irritation to the pulp. It's like making itself a little band-aid to protect itself. And we've got our cementum. So cementum, remember, this just covers the root. There's no cementum on the crown. This is just the covering of the root. It's very, very strong. It's formed by the cementoblasts. We have primary cementum and secondary cementum. Primary cementum, this is also called acellular cementum, formed outward from the CEJ, covers the full length of the root. The secondary cementum, this is on the apical half of the root, and it's also called cellular cementum. Big purpose of cementum, this is to anchor the tooth into the socket by attaching to the periodontium. And we've got our pulp. So different types of pulp make up the pulp. With a coronal pulp, this is what is in the coronal portion of the tooth, right? It has its pulp horns, which are the areas of the pulp chamber where it kind of like sticks up towards the cusps. We have radicular pulp. This kind of, I always think radicular, like radiate, like it radiates out of the coronal pulp. It's the radicular pulp is what goes down into the roots towards the apex. In young teeth, the apical foramen, which is the opening at the bottom of the tooth, that apical foramen is very wide, and with age, things can happen, and it starts to kind of decrease in size. So the apical foramen gets smaller with age. Pulp made up of blood vessels, nerves. It contains connective tissue, intracellular substance, tissue fluid, lots of stuff in there. Fibroblasts are the cells that are responsible for the formation of the intracellular substance. And then the periodontium. So periodontium, this supports the teeth in the bone. We've got the cementum, the bone, and the periodontal ligament. These are the structures that make up what we consider the periodontium. And then we can divide that further into 2 things. We can divide that into the attachment apparatus and the gingival unit. So the attachment apparatus, this has got the cementum, the alveolar process, and the periodontal ligament. The tissues work together to support and keep the tooth in place so that it can function and do its job. Alveolar process, we know that this is the bone, right? And it's the extension of bone in the mandible and the maxilla, supports the teeth, holds them in place, right? The alveolar process is the bone. We've got the cortical plate. That's the dense outer covering of the bone. It's really strong. The alveolar crest, that is the highest point of the alveolar ridge in between the teeth. And when we look at x-rays, like specifically bite wings, we are looking at the level of that alveolar crest when we're looking at bone level, it's going to help us determine periodontal disease. So alveolar crest really helps us determine the health of the periodontium. The alveolar socket, that's the cavity where the tooth sits. Remember that the tooth doesn't actually contact the bone, but that periodontal ligament supports it, kind of like a trampoline, right? Like the periodontal ligament is the springs of the trampoline that kind of hold it in place. And then the lamina dura, that's also known as the cribriform plate, and that's thin, compact bone that lines the inside of the socket. So the lamina dura is what lines the inside of the socket. The periodontal ligament, dense connective tissue, we organize this into what we call fiber groups that connect the cementum to the bone. The functions, it's supportive and protective. It's got a sensory function. It's nutritive. It receives nutrition from the blood vessels, and it's formative and resorptive. So lots of functions. Periodontal ligament is pretty important in the overall health of the periodontium, which then affects the health of the tooth. We have our fiber groups. We have horizontal fibers, which are horizontal. We have obliques, which go kind of upwards or obliquely, which kind of diagonally. Apical fibers, those are going to be found around the apex. And interradicular fibers, these are on multi-rooted teeth, and they are going to be like in between the root, right? Like in between the two roots. Those are the interradicular fibers. Transeptal fibers, these are above the alveolar crest in between a tooth, and they go tooth to tooth. Interdental fibers. I'm not going to ask you questions about this. And then more specific fibers. We have dentinogingival, alveologingival, the circular fibers, and the dentinoperiosteal fibers. I won't ask you questions about this on this quiz, but I think I did on the last one. I know I asked you like a circular fiber question at some point, but different fibers, they're usually named for kind of what their position is within the periodontium. And they all just function to support all these structures with each other. All right, the gingival unit. So the gingival unit is the oral mucosa that almost continuously lines the oral cavity. It's composed of a stratified squamous epithelium that overlies or is on top of connective tissue. It includes the ducts of the salivary glands, and there are 3 types of mucosa. We have lining, masticatory, and specialized. The lining mucosa is softer. It's got a moist surface. It can stretch and be compressed, very flexible. It covers the inside of the cheeks, the vestibule, soft palate, the tongue. It's not attached to bones, so that's why it's very free moving. Very abundant blood supply, which is why it's usually very bright red or dark pink kind of color. Sometimes we can see the blood vessels through it. Masticatory mucosa, this has more of a rubbery surface texture and it's really resilient. The attached gingiva, which you can see like, so this would be our lining mucosa, then attached gingiva would be like up here. This is like immovable. So it's something that's not going to be a movable type of mucosa. The dorsum of the tongue is also masticatory, which I guess we could consider that movable, but when we look at color, it's usually light pink and it's keratinized. It's very firmly attached to the bone and does not move, except for the tongue, right? Tongue's going to move. And then specialized mucosa. When we're talking about the specialized mucosa in the mouth, on the dorsum of the tongue, we have specialized mucosa, which is the papilla, right? So the masticatory makes up like the dorsum of the tongue, like the main body of it, but then the papilla are considered specialized. All right, and our reminders for this class is that next week, first thing we will have a quiz, and then we also have the worksheet, which again, I just remind you, I know I said it before, but I will post that on D2L, so you can do that digitally or turn it in person. I'm going to stop sharing, and I want to take a quick look at the quiz because I want to see if I kind of gave you guys some good hints. Make sure I'm not actually sharing it with you when I look at it. Okay, we talked about knowing which kind of what cells form what, right? What cells do what cells form what. Knowing all the differences between those. Difference between the anatomical and the clinical crown. I would know when you look at the bud, cap, and bell stage, what are kind of like, what is mainly happening? Like big picture, what's happening during those stages? We talked about what's the hardest substance in the body. Hint, it's not dentin. We talked about the stomodium, so knowing what the stomodium is. Where are the first signs of tooth development going to be found? We mentioned that. Okay, and then there's one tricky one, so I'm going to give you guys a hint on this one. Let's see, how do I want to word this for you? Okay, so like what part of during tooth formation, what is responsible for formation of the dentin? Like what part of the tooth is responsible for dentin formation? That's as much as I'm going to give you on that. But what part of the tooth during tooth formation, what part of the tooth is responsible for dentin formation? So I'm not asking what cell is responsible for that. What part of the tooth during formation is responsible for dentin formation? Hopefully that leads you somewhere. Okay. All right. Any questions about that lecture? Any questions about anything? All right. Well, that's all I got for you guys. I will go ahead and post both of those worksheets in D2L right now for each class so that you have those. And there'll be an assignment folder that you can submit to if you'd like. And then, yeah, you can submit it in person if you'd like as well. I hope you guys have a good rest of your day. Stay safe with the ice out there. Hopefully you guys all have power. And hopefully I'll see you guys next week. Have a good one.
Thank you.